currently in the waiting room. We were just waiting to see if more people were gonna come, and then like start
Okay.
exactly at 1:30.
Okay.
Yeah.
Sounds good.
Are you currently in your office in the hospital? That's so cool.
Yes, this is my office. That background is my son's artwork, so that throws people off sometimes. But yeah, I'm in my office right now.
Oh, so yeah, we currently have like 40 people waiting to come in. So yeah.
Okay, okay. And are they where are they all students, undergrads?
Yeah,
Yeah.
they're all undergrads, but they're not. But
Sorry,
they're not from like.
I didn't hear that.
Yeah, most of them are undergrads, kind of like from all over the U.S. that kind of signed up through our program online.
Oh, that's very creative and innovative. So the two of you started this.
Yep.
Yeah. Yeah. So basically we're kind of letting the doctor side how they want to run this. We've had other doctors like just kind of like start talking about their background, how they got into medical school, what their day-to-day life is.
Sure.
And then like we let people ask questions. There's some people that already like pre-ask questions, and we have a list of it.
Yeah.
But then last time they just kind of just went for it, and they started asking questions like on the spot. It's kind of just how you want it. You can like have them.
Oh, since you've done this before, tell me what works. I have done a couple of these sort of, sessions with our surgery interest group at U of M. And so for them, I did it as a PowerPoint. So I actually have something ready if you want that. Or if what's worked is a more impromptu thing, I'm perfectly fine with that too. So why don't you tell me what seems to, flow better and what makes, whatever gives you the best use of this time. So I'm willing to do whatever.
If you have a PowerPoint, that would
PowerPoint would be good, and then they can come in with their questions at the end or however you want to answer them.
Yeah, it's pretty short anyway. It's like a 10-minute thing. So I can, if you want to start off with that, I can do that.
Okay.
Yeah.
I'm going to let them all in.
Okay.
Hi, everybody. Welcome to today's virtual shadowing experience. Today we have Dr. Madhuri Rao. She's currently in the Department of Surgery at the U of M. So I'm going to kind of let her take it away and introduce herself through her PowerPoint.
Thank you. Let me just make sure I can share this. Oh, I think, are you able to let me share?
Yeah, I'm gonna make you a co-host.
Okay.
Okay.
All right. Well, first of all, it's so nice to see so many of you here, and congrats to Shubjot and Navjot for making this happen. And it's really nice to see all of you here and trying to make best use of these weird times. So welcome and thank you for the opportunity.
My online shadowing thing.
Oh, it's so weird.
Nakaro.
Okay, let me get.
You want to mute everybody?
Yeah.
All right.
Okay. Dr. Rao, could you just unmute yourself?
Oh, sorry. So I guess you didn't hear all of that. I was just saying it's so nice to see all of you, so many of you making best use of these weird times, and congrats to Shivjot and Navjot for making this happen. And that's very enterprising. That's great. So I am a thoracic surgeon at the University of Minnesota, and I've been here for 5 years now. Sorry, give me 1 sec. And I've had a great time here. And just to, I'm just going to briefly tell you how I got to this point, and that might open up some questions for you. And, I'm happy to discuss and talk to you about anything else you might be interested in. Um, so basically, I was born and brought up in India, and I went to medical school in Bangalore in India. And then as I was nearing the end of medical school, I sort of realized that that was the best time for me to sort of step out and see what was going on in the rest of the world. And training was great in India and everything, but it's more by numbers than by system. It's sort of a little bit hit or miss. So with all that in mind, and especially for surgical training, I wanted to just see what was out there in terms of, surgical techniques and what was going on out there. So that's and UK seemed to be a good option at that point for various reasons. And so that's where I went off to after my internship, and I did my basic surgical training there, and I got my MRCS, which is the Member of Royal College of Surgeons. And somewhere along the way, that's when the European Working Time Directive was coming in, meaning that no one, including trainees, could work for more than 40 hours and max of 52 hours for surgical trainees. And as much as we complain about working hours now, it just didn't seem adequate for good surgical training. And that, together with some other factors, made me want to transition to the US for better opportunities. And so that's when I moved to the US in 2008. And I knew it was going to be a long road, being an international graduate in the US, but I was prepared for it. And I started off with my preliminary surgical residency. I did 2 years of that and then got into a categorical spot. And I finished up my surgical residency, and that was in New York. I went to SUNY Downstate in New York, and then did my cardiothoracic surgery fellowship at Mount Sinai, also in New York. And then soon after I finished my fellowship, a few job opportunities came up, and some in New York, and then this one here. And when I interviewed here, it was pretty, I knew that I wanted to be here. Everything just seemed to sit right here. A little bit about my personal life. I got married in my second year of surgical residency, and I had a little boy during my chief resident here. He's now 6.5. And, as I just mentioned, we have been in a few different places. The first 2 to 3 years were pretty busy. Now the last couple of years we have more partners. There's a little bit more flexibility. My current commitments, this is an academic institute, as you know, it's the University of Minnesota, and so it's a faculty position. So clinically, I'm very busy. There's operating, there's clinics, there's planning for patients, rounding, investing in new techniques, and education and things like that. And there's academic stuff, which includes clinical research activities. I'm not so much into bench research, but clinical research activities, and we're expected to have publications and presentations at national and international meetings, and other sort of professional development activities, like being part of surgical committees, mentoring, and my special interest is mentoring women interested in surgery, and also developing the robotic surgery program here. I'm the chairperson for the robotic steering committee at the university, and so that's a big part of what I do in terms of development as well. I have never had, never is a strong word, but for the most part, haven't had any regrets. Whenever I've objectively thought about this, I've never had any regrets about picking this life for myself. I work with a group of very dynamic, enthusiastic, and smart people, and that sort of keeps my day going. It's really something that is a driving force on a day-to-day level. There's so much room for innovation. There's so much room for improvement on a daily basis here. It's keeps your mind and body active, and I like that. And honestly, my thought was that to be good in any field, you have to work hard. You cannot, if you have to be a teacher and be good at it, you have to work hard. If you have to be in IT and be good at it, you have to work really hard. And if you want to reach your best and reach your pinnacle, you have to work hard at anything. And so this is what I liked, and so why not work hard at this? in terms of surgery, feel like this is really a great combination of, within medicine, it's such a great combination of technical skills, medical knowledge, new innovations. And I feel like that's what makes me, at least, a complete doctor. Very often I get, I actually not so much right now, but initial years, you're sort of second guess yourself. Do I have to be aggressive? What sort of a field is, will I be able to make it here? I think a lot of that is myth. It's mostly very nice people. They're going to be, characters in every field. And so I think, I haven't had, cannot generalize to the extent that surgery is a aggressive field. I think you have to be assertive to get your point across, and that's, again, I think if you have to progress in any field, you have to do that. And knowing to put your foot down and not be afraid to ask what you don't know. Those are the things that I think really matter. If there's anything, I don't know if you would really call it negative points, but it's something that I guess you need to be aware of. In terms of work-life balance, it's not, I don't think there's ever such a thing as balance, especially in this field. It's about prioritizing, and, one is going to win over the other always. It's going to be impossible to have the best of both at the same time. And it's going to be your personal choices and priorities to decide which one you want to pick at what time. And so just consciously knowing that and, being aware of it. And most times, a lot of surgeons or people in any busy job will tend to put family time aside, and it's just important to be cognizant of that and know that it needs more active planning and a proactive attitude when you're in a busy job. It's definitely something that everyone, whoever, if you really want to do something, you can do it, and having supportive partners, supportive family, definitely would help a lot. That's sort of my quick overview, but I'm happy to discuss whatever you want to go into detail about.
One of the first questions that we've gotten have been like, how have you kind of adjusted in your field with like regards to your race, sex, and gender kind of fitting into maybe like a male dominated field or something like that? How did you kind of adjust?
I think it's hard to ignore the fact that there are differences. I think it would be a lie to yourself and to everyone else if you said that there was no difference. I wouldn't say that I see it on a daily basis, but there have been several different times when, I've had to face that. So in terms of race, I must say, and I'm going to be pretty open here. I think it's important to just, say it as it is. And this is my personal opinion. And, it's sort of a little bit of everything. But I felt like the US was definitely more open than Europe. Just having been in India versus UK versus here, I think that does give me a little bit more of a perspective. And I felt like the US was definitely more open in terms of the racial acceptance. There's definitely, in terms of, at least in the working group with your colleagues, with the patients, it's something that, you see, they're surprised to see an Indian woman surgeon. Like, oh, you're the surgeon? So it's, I face those kind of things, and things like, when you get into a room and, they're the very typical talking to the white male intern as if they're the doctor, ignoring your presence. So I think the way I deal with that is being very rooted in what you know you are. So you're not, I feel like I'm not here to prove something to someone else. There are times when you have to stand up and put your foot down and say, this is my word, this is how it has to be, or, this is my opinion. And that takes a lot of practice and growing into that new skin. But, there are other times when it really doesn't matter. And so I think it's important to pick your battles. For me, it's been, am I going to waste my energy explaining to, a farmer from North Dakota about women's rights in a half an hour clinic visit? Or, am I going to just try to give him the best care possible, just making sure that he's comfortable with the care I'm giving him? So I think important to recognize your strengths and abilities. Important to also, the other thing that has helped is mentorship. So having strong male and female mentors. So that's in terms of the gender part of it. I think knowing that, it's important to have not just females that support you, but also male mentors in positions that can be helpful. So sort of trying to find people that can help you progress in your development with that. And then just consciously thinking about some of these things and knowing what to work towards. Does that answer your question?
Yep, that does. Another main topic that we've kind of discussed a lot is mental health. It's kind of being given more attention recently over the past few years. How do you as a doctor and also like just as a regular person deal with like the stress and anxiety of taking care of yourself and your patients and kind of coping and kind of how you strategize dealing with that?
I think most of us, and I can say this because we've, as a group, we talk about this a lot. Most of us are not very good with that. Again, it has to be a very conscious effort. So some of the things that I've tried is, meditation. So transcendental meditation is something that I started doing pretty during my med school years, actually. And I was actually pretty good with that until recently, until I started my job and my fellowship and my job, and that sort of waned off. But I think having something really concrete like that you do, like an activity that you do, be it meditation or yoga or exercise or going to the gym or having something outside of your mainstream is very important. I think also being one of the things that I've learned is looking at things in a more critical rather than a defensive way. So a lot of things, especially in a job like this, can be stressful. Someone asks you a question or questions you about your practice, or something doesn't go right. A lot of these can be stressful. So thinking about it, you deal with the initial emotion. Okay, you're going to get angry, you're going to get upset, you're going to be sad. Let that be. And then once you're done with that phase, then evaluating it very, very objectively in terms of, could I really have done this better? Could I, what can I do to not let this happen again? Or how can I make it better? So being very, trying to be rational about your thoughts and, processes. I think that's another thing that's helped me. And then having someone to talk to, and be it, whether it's family, friends, colleagues at work, I think any of that, just being able to release your emotions with someone, I think that's helpful too.
That was a really great answer. Thank you for taking your time with that one. There's some questions happening in the chat, so I'm going to start kind of going through them, and then we'll go from there. What goes on your mind before a surgery? How do you personally prep for a surgery?
Very nice question, because there's no surgery that's a simple surgery. So the cases that I do, for example, can range from an endoscopy, which is considered simple, when you just put the scope in and, take a look and, either do a stent or something else, to something very complex, like taking out the whole lung and being on, potentially, cardiac bypass backup and stuff like that. So I think, but never say it's just as something, just an endoscopy, because even the smallest case has potential to go real bad when someone's under general anesthesia, or, anything can happen. So some of as you go through the years, some of these tend to become a little bit more routine, and you're like, okay, something can go wrong, but I know that this is what I have to do. I always take, when I scrub, I just take 30 seconds to just, while I'm scrubbing, I just sort of, close my eyes for 30 seconds and just let things sort of neutralize for a little bit. The other thing that I do in terms of preparation is nothing can beat actually being well prepared. So knowing your patient, being meticulous about, all the tests that they've had, going through the scans, studies, whatever else. So all that pre-prep that you do the night before, that's very important. And I think also just knowing that, when you are in that position, just focusing on that one patient. Don't worry about anything else that's going on. And I also go through, for anything that's a little more involved, I just go through the steps in my mind, either the morning of, and and that's something that I think a lot of people do, from what I've heard, for any complex procedure or things that have several steps, just going through it in your mind to say, this is how I'm going to do it. This could happen. If this happens, this is what I'm going to do, having a backup plan. So all those things, just sort of quickly reviewing in my mind. But so there are some concrete things like that. And then there are some other things like I said, just take a moment, ground back to zero, and then start.
Thank you so much for that answer. And then there's another question. We have a couple of pre-PA students here too, and they're kind of wondering, like, have you ever considered being a PA, or what made you become a doctor over a PA? And like, as a doctor, how do you work with the PA, and like, how does that relationship work?
Sure, great. So for me, I think when I made the decision to be a doctor, I don't think the whole PA concept was even in existence. So, but I sort of, I knew I wanted to be a doctor or a pilot, I guess, and I don't know what finally took me to being a doctor, but I think I knew it was so I think there was a little bit of family influence. I definitely not pressure, but my father's a doctor, and I sort of got exposed to the hospital scenario pretty early on in life, and that really interested me. And so I think it wasn't very difficult for me to decide about being a doctor. I thought I was going to be a neurologist, but my first surgical rotation, I knew that that's what I wanted to do. It was just one of those things where I just knew my heart was in it, and I pursued it. In terms of the PA, I think my first exposure to PAs was actually during my training in UK, and then when I came here. But I think it's a great field. I think there's so much potential. So we here, the way our setup is here, we have 2 PAs on the floor that help with a lot of floor activity, like include managing daily things on the floor, and also procedures like assisting with surgeries, and being the bedside person for the robotic cases. And also procedures like, simple bedside procedures like bronchoscopies, or, things like dressings, and, anything that may require some degree of expertise, but not necessarily having to, do it individually in the OR. So those are the floor things that they can do. And then of course there are PAs that train to be surgical assistants. And so we have a few of them here as well. And, so if that's your particular interest, we work with PAs a lot on that. And they're actually pretty much a lot of an experienced PA is, a lot of times we rely more on them than the junior resident that comes in, because they've done so much and know so much already. So it's a very collegial relationship that we have. And then we also have in the outpatient setting, we have here we have clinical nurse specialists, but several other places have PAs. And where I did fellowship, we had PAs. So coordinating patient care plans, being in touch with the patients to let them know, this is what we discussed, this is what we decided about you, and do you have any questions? So I think there's a lot of scope in terms of clinical work. There's also a lot of scope in terms of academic, uh, for academic opportunities in terms of, there are a lot of peers that work with us that we work together on projects and publications and presentations and things like that. So, and we, here at least we try to involve PAs and advanced practice practitioners as much as we can with a lot of our activity. So I think it's hard for me to say if I would have picked one over the other because I wasn't in that particular position. But I think it's the way things are now. There's so much opportunity and so much scope, and I think it's a very if you are at I don't know if the question also intended just in terms of the relationship between the physicians and the PAs. I haven't seen. I think everything that I've seen has been very positive.
Thank you so much. I was really a lot of people have been curious about the PA relationship, and that's amazing that we got it from a doctor's perspective too. Because I know a lot of people hear physician assistant, they hear a doctor's assistant, they don't actually acknowledge what it is. So thank you so much for answering that question. This question we were getting a lot through the chat is what specifically is your specialty? What do you do in it? What is your day-to-day setup, and why did you specifically choose that specialty in surgery?
So for me, just starting off with why what it is, let me tell you what it is. So I guess in the proper sense of so I'm a cardiothoracic surgeon, but that used to be under one umbrella until a few years ago. So that's heart and lung surgery, so anything in the chest basically. So it's heart, lung, esophagus, anything in the middle of the chest, which is called the mediastinum. So the thymus gland and all that stuff. So anything in the thorax region was considered cardiothoracic surgery. Now, given that heart surgery is such a involved, so there's heart surgery and then there's everything else, because for almost all heart surgeries you require bypass, and it's totally different skill set. So what then started happening over the last few years was it's still under cardiothoracic surgery, but the way we're trained is you can choose to be one or the other. So you train in both, but your practice can be more directed towards being mostly cardiac or mostly what you call general thoracic. I suspect in a few years' time it'll, sort of diverge a little bit more. But right now there's still quite a few places which do, the more rural parts will still do, the cardiac surgeons will still do general thoracic, and it's the same person that will do heart and lungs. But for the most part, the training, you train in both. So I trained in heart surgery and lung and esophageal, but my interest was more the lung and esophagus and everything other than the heart. And so I stayed with them. So, so that's general thoracic and foregut is what that comes under. So what that involves basically is a lot of oncology stuff, so cancer stuff. So lung cancers, esophageal cancers, mediastinal cancers, like thymic cancers and things like that. And then we also do benign stuff, so non-cancer stuff. So things like random lung nodules, lung biopsies, infections of the lung that need surgery, things like that. And benign esophageal problems that we deal with are hernias, hiatal hernias. So, when you have some stomach going up into the chest, or intra-abdominal contents going up into the chest. So hiatal hernias, difficulty swallowing, any foregut, any esophageal problems that are not necessarily cancer. Other than that, there's also a little, sprinkling of endoscopies and all those, other kinds of minor procedures. My special interest is also in mesothelioma. That's something that I trained with. Where I did fellowship, we did a lot of that. So mesothelioma of the pleura or of the lung is another part, but that still comes under lung cancers. So those are sort of the diseases that we deal with. The surgeries that we do for most of these days, 90% of cases we do with what's called thoracoscopic surgery. For those of you that haven't heard of it, it's, basically like laparoscopic, so small incisions. So usually, anywhere from 1 to 4 small incisions in the chest. So using, cameras and small instruments. And we can take out, portions of the lung, all of the lung on one side. All of that can be done with small incisions, and that's made a huge difference to the way patients respond. So that's and then there's robotic surgery. So small incisions, but using the robot, that gives you more technical, more sort of replicates wrist movements rather than doing it with stick-like movements. So those are the ways that we do surgery, and so the procedures involve, taking out portions of the lung, taking out portions of the esophagus and stomach for esophageal cancer, for example, hernia repair. So all of this, like I said, 90% of, about 85% of cases we do with minimally invasive techniques. And sometimes there are just some really big cases, or, if there's a complication or something, we'll have to make a bigger incision. And so that's also something that's in our things to do. So why I chose this particular thing and what my regular week or day is like. So for me, I think it was just like I decided on my first surgical rotation that this was it. It was just one of those things so in surgery, my second year of surgery, I went into a thoracic case, and it was just amazing. And it was just really, the physiology interested me. The technical aspects interested me. The fact that you're not always dealing with older patients or younger patients, it's a mix of both. The fact that you're not always dealing with cancer. There's a good amount of cancer, but it's not always cancer. So there's a range of pathologies. There's a range of age groups. We deal with a lot of young patients in their 20s for hyperhidrosis, so excessive sweating. So a lot of those patients are like, they come in, get the procedure, go home the same day. So those kind of things. So there's a wide variety of pathology. There's a wide variety of age groups, a lot of technical innovations that can be made. So all that sort of really interested me, and that's why I picked it. What my routine week is like. So rather than a day, I'll tell you what my week is like, because it's not just surgery, it's not just operating. Monday, Wednesday, Friday are my operating days. And usually there could be anywhere from 1 to 3 cases, depending on. A lot of times our surgeries are, anywhere from 5 to 6 hours. So if it's that kind of a case, it may be one small case in one of those cases, or they could be like 3 minor cases. So but that's sort of distributed. And so Monday, Wednesday, Fridays are my operating days. I have one clinic day. So Thursday is my clinic day. And then Tuesday is a sort of, in between, do all the other stuff. So like meetings, conferences, planning for the week. We have, we sit down and go through all the patients that are going to have surgery the coming week. So that's sort of what, what the overall week looks like. Usually start at around 6:30, 7 o'clock, more like 6:30. I'm here by 6:30 because most OR days start at 7:30. So you have to be here and check in the patient by 7 o'clock so that things can get moving. The finishing time is very variable. If everything goes as planned, usually it's about 6 o'clock or so, 5, 6 o'clock. There are about, a few days that, may finish at around 3 o'clock or so and you'll be done. And there are quite a few days when things can go over, or you end up helping someone else, or, something doesn't go as planned, and it could be 8, 9, 10 o'clock. And I think just to give you a sense of the setup, so in general thoracic, here we have 4 partners. Most university places would be set up in some sort of a way where there's, anywhere from 2 to 5 partners, depending on the size of the department. And so we take turns being on call. So the on-call person is the one that usually takes the brunt of, having to stay later or taking the emergencies and all that stuff. So, but that's, and it's important to have a good group of people, which I'm fortunate we do.
Thank you so much. That was a really thorough and great answer. You mentioned before that you were involved with clinical research. Could you kind of talk about what you kind of did there, and then how it kind of aligned with your like daily or weekly life as just a thoracic surgeon as well.
Yeah. So most of the research, or all of the research that I have done, has been work-based or like clinical-based. Um, I haven't, I haven't done any time off for research. So basically, that means, I've looked at opportunities within my work environment to be able to publish or present. So some of the things, for example, have been newer techniques in the surgery that we do. So for example, just a different approach. So there are a couple of procedures that we do that are routinely done, or like 90% of the US does it through the chest. But we explored a technique of doing it through the abdomen. So we're looking at outcomes from that. So a lot of this clinical research is outcomes-based research. So we'll compare two different techniques and say, and we have someone here who's a database manager, and so they can pull the data for us in terms of patient's length of stay, pain management, complications, all those things. So usually it'll be like comparing two different methods and seeing, did this, is one better than the other? Did they have comparable outcomes? Things like that. And that's where, we have students and residents help us with a lot of that. And so they usually get their names on the paper or the publication. And we try to present these at national and international meetings for thoracic surgery. So that's one thing. The other things are, usually in a university setting, it's encouraged to look at educational research as well. So is some modification that you've made or some curriculum that you've built, is that helping students or is that helping residents? What was the pre and post? So things like that. Those are sort of that's the rough idea in terms of the kind of research, clinical research that I do. And organizing time, it is hard, especially with a busy clinical practice. I try to keep one day every other week for this, but it gets hard sometimes. It does end up that, a lot of times when you're actively working on a project, it's going to be on your own time. So, either weekends or evenings or nights or early mornings or something. Again, that's where the balance part comes into play.
Thank you so much for that answer. And this one question we got is, would you mind elaborating on robotic surgeries and how are they being incorporated into nowadays surgeries? Like, I feel like I hear so much about how robots are like kind of taking over in the surgery field, and kind of how is that happening? Like,
sure, yeah. So it's been around for a little bit now, for close to about 15 years or so, and it's really I think it depends a lot on the specialty. So robotic surgery, just as a base, is just another type of minimally invasive surgery. What's special about it is that the view that you have. So it's still camera view, but you have a 3D view, and it's a 10-time magnification. So those are the advantages with the view over, say, regular laparoscopic or thoracoscopic camera, because that's you're getting a 2D image with about 3 times magnification. The other thing is the instruments that they have the basically wrist-like action. So they have that, as opposed to with laparoscopic or thoracoscopic, it's chopsticks. So in terms of, so those are the advantages. Now, of course, the one common theme you'll hear is not about whether it's the robot or it's laparoscopic or open. It's about the person doing it. So someone that's that can do a surgery well thoracoscopically or laparoscopically will likely be able to do a robotic surgery well as well. Someone that has no clue about what's happening with an open surgery is unlikely to be able to do a robotic surgery. So it doesn't change the expertise or the skill. It adds to some factors. So in the fields of urology and GYN, it has completely taken over pretty much. The area that they work in, deep in the pelvis, the robot actually gives the angles of visualization and the movements and all that stuff is a big plus for them. So they adopted it pretty early. And although originally it was meant for cardiac surgery, I think the first when it first came out, it was targeted towards cardiac, but it seems like urology and GYN made the best use of it. And so they, a lot of their surgeries have been robotic for a long time. The other specialties have slowly taken in, and now I think it's at a point where most trainees are coming out having done some robotic, but it's still not a required, especially and I'm talking about general surgery at this point. For urology and GYN, it is required, but for us, it's for general surgery and general surgical specialties. It's most of them, I would say about 60-70% of them are coming out robotically trained. But it's not yet completely taken over. I'm not sure. There's still a lot of resistance, especially in specialties like thoracic, where you need to have really good control because we're working your big blood vessels. And so you have, the way it's set up is that there is a robot with the arms docked at the patient. There is one person assisting, and that's where a lot of times that we have a PA experience, that's experienced in this rather than having changing residents. So there's one person who knows what they're doing at the bedside, and the surgeon sits at the console in the same room, of course, operating with, your fingers and with the instruments looking into the console. So it's very important. So if there's a big bleed or complication, you need to be able to get in there and get to that point right away. So some specialties have, thoracic has, cardiac have, hesitated a little bit, but I think it is quickly getting more and more popular. I think within the next 10-15 years, it'll be sort of the way most things are done.
Okay, thank you. That was a really great answer. A repeating question I'm seeing is, what are some of the most, I think since it's surgery, like what are some of the most difficult and challenging aspects of it? With thoracic surgery?
Sure. So I think it's just the intensity of it, surgery itself for one, and then and then specifically going to cardiothoracic as well. The stakes are high. It's just it just requires. It's not. It's. I think. I don't think it's so much that, oh, you can do it, you can't do it. I think it's about how intense you're willing to be. There are no shortcuts, and there's no room for there's very little room for error. So I think despite your best efforts, there's going to be things that go wrong. And so trying to minimize that chance factor by doing the best you can and being really sort of spot on about things and willing to be that focused and intense about what you do, I think that's an important thing to keep in mind. So the challenges, that was your question, right? In terms of what are the challenges in terms of surgery and thoracic? I think overall, just knowing that it's such a, stressful, when you're at work, that's everything. You can't really, there's not much room to do much else. So I think just, being, again, like I said, being in a good practice, being with a good group of partners, having good support staff. It's all, end of the day, it does come down to teamwork. There's no way one surgeon can be successful without having a good supportive group. So just sort of being very conscious about all of that when you get into something like that. That's one thing. Other challenges, I think, just just again, the whole thinking about timing, thinking about the years in training and all that stuff, being mentally prepared for that. It's not something that that's going to there's no way to reduce that or change that much. So just knowing what you're getting into, and making a conscious effort to balance out these things. And then the other thing that I sort of covered earlier was the challenges, work life, and trying to figure out when what is important. And I'll just take this opportunity to say, yes, it's maybe a little bit more thinking for women than for I wouldn't say than for men. I think it's a little bit more of active thinking for both parties. But there are, but I think the way we have a lot of groups like, Women in Thoracic Surgery Association, Women Surgeons, there are a lot of resources that you can look to get information on things like this.
Okay, thank you so much for that answer. And then one question we're getting is a couple times is how would you recommend taking a gap year before undergrad, and like what do you think someone can do in their gap year that would like optimize their application chances of getting accepted, and like kind of like what do you think would make like an applicant stand out for medical school?
So disclaimer that I didn't go to med school and undergrad here, and so my perception of that whole process may not be accurate. But I mean, I have seen students who've taken, a gap year or have done things during their vacation time or their summer vacation time. But in terms of when we look at applications, I think it's knowing that you've used it in some way that's productive. And so long as you can explain that, and that could just be, going somewhere on a trip somewhere, but so long as you did it with a purpose or some justifiable reason, I think that would be okay. The other things that people have done that we've supported here are observerships. Being I don't think you can do more than I can't remember if it's a day or a week, but you can tag along with surgeons to just get your face in there so they know who you are when you apply. So doing something like that, or just to get a sense of what's going on. You hear about all this stuff, but you have no sense what a hospital might look like or what an OR might look like. Some people may love it and some people may just not want to be in that environment at all. So sort of coming in, getting to know what's going on in the hospitals. The other thing that you can do that I mentioned is being I think we've done this once or twice before, having undergrads be part of some of the research work that we do. So a lot of this is like, chart review. And so if you're interested, then we can, obviously you'll have to get through all the hoops to get get Epic access and stuff, but it's not too bad actually. And some people have done that and helping out with, the data managing and analysis and stuff like that. And that can get your name on papers or publications or even presentations, and things like that can help out when you apply.
One question is, how has COVID impacted your work environment and experience?
It's different. It's I must say March and April were the times that we noticed most of a difference really, because we weren't really coming to the hospital the whole time. We were taking turns to be here, and between us 4 partners, we were just being here, and our volumes had gone down to less than 50%. But honestly, since June, it's back up to close to, just past 90% actually. And so we haven't noticed a big change in terms of the workload. I think what we saw was, how to manage things in a crisis. And I think in overall, the medical community did really work pretty well. And I'd say particularly even in surgery, because within the first month, we had a lot of guidelines and things going on through the ACS, which is the American College of Surgeons, through the STS, which is the Society of Thoracic Surgeons. So a lot of these, associations came up with very very doable guidelines, like, okay, these are the people that you're going to operate on. They're going to be, and this is how you're going to classify phase 1, phase 2, phase 3. Phase 1 is if your hospital is not, really, or if you're, I can't remember which way they did it, but one would be if your hospital is really affected by this, then, you're not even, unless it's life or death, you're not doing surgeries. Versus, if it's like in a manageable, like Minnesota has been pretty manageable all through. So we stopped doing like elective cases. We stopped doing cancers that were, could wait a couple of months, but more aggressive cancers we continued to do. And so sort of having that, we saw how we could stratify. We saw how we could implement something like this. Just managing in terms of altered workload. Our support staff wasn't coming in all the time. We had them just working from home, having Zoom conferences in terms of instead of our meetings, and getting adjusted to that, and actually realizing that quite a few situations actually had better turnout than having a real meeting. And so I think we had that was one thing. The other thing was the whole thing with the virtual visits. So we have a lot of patients coming from far away places. So we cover 5 states actually. And so people coming from the Dakotas and Wisconsin, and they would come traveling all the way for this one visit that may not even we may end up saying you don't need surgery. So the virtual visits really altered that. And there was, I think that people were looking at virtual visits, but there was a lot of red tape to get to that point. But what COVID did was to just abbreviate all of that, and we've been doing very successful virtual visits. So that was, I think of all the things, that was the biggest plus that came out of this.
Since you said like the virtual meetings, do you think that's gonna stay even after COVID? Isn't really a problem anymore? You think that's gonna become like a regular thing now?
Yeah, I think we're definitely going to use it more than I do. I think there are some insurance issues and coverage issues and things like that. So I don't know that it will completely replace it, but I think we'll definitely be utilizing it a lot more.
All right. I'm gonna ask one more question in the chat, and then like afterwards, you guys can start raising your hands, and then we'll like let you talk and ask it yourself. And this question is more like a kind of like a fun question. As like a surgeon, what is your perspective and your like opinion on medical dramas? There's like so many of them, and I know like some doctors like really hate them, and some doctors just think they're like whatever. Like, what's your opinion on like shows like Grey's Anatomy or like The Resident?
Sure, yeah. I actually sort of enjoy those just because I can, look at it and be like, well, some of them are more realistic and some others are not. But somehow, weirdly, I do gravitate towards those and watch those just because some of it is relatable. And you're like, oh, this is what I would have done. But I would say, I think ER actually, not ER, which was the one with Scrubs. I think Scrubs was, although it was a comedy, it was, I think that day-to-day resident life was actually closest of a reflection you'll get of of resident life. Grey's Anatomy is a lot of glamour, and that's I don't think that sort of stuff happens. It's just fun, but yeah, I mean, I personally do end up watching most of the medical shows. Yeah.
That was really like awesome. Now you guys can like just like raise your hands, and then we'll let you unmute yourselves, and you guys can ask the questions you want instead of writing in the chat. You guys can still write in the chat if you are like uncomfortable of asking.
Have you ever had to kind of deal with a patient that was making you feel uncomfortable or maybe even unsafe? And if so, how did you deal with that?
Yes, good question. The first one, it's happened a handful of times, but one that really comes to mind is there was someone that was actually threatening, and we had heard that he had weapons at home and had threatened people. And well, the thing is, you as as a doctor, you are allowed to refuse, but refuse to see a patient, but not. But you should make sure that they have some other established care, or someone's going to take care of it, or you've set them up with behavioral health or whatever else. So, and then also, if they come into clinic and they get violent, you can walk away. But if someone's, just had all this background information, but you don't have concrete data, then you're sort of expected to, go in there and see what's going on. So what we do a lot of times, and what we did for this person, was just make sure that, we had security. So I went in with security to see, or security was standing right outside the door, and we had the door open. And I went in and did my consultation, and then and I think we established before starting the consultation that, hey, look, we've had some of this information, so that's why we have security here. If there's any issue, I'm going to walk out, and so let's just try to keep this as calm as possible. And for the most part, when there's been a situation, just sort of being firm about it and having all this backup has helped. I can't. There have been times when they haven't been that responsive. In which case you've just had to say, okay, I'm leaving now, and we'll set up another appointment. And then there is this thing in place called behavioral agreement. And so if someone's been consistently not or behaving like this, then they have to sign a behavior agreement before they come in to see you in clinic. So yeah, there are measures in place, and I think so long as you're aware of it, it's manageable.
Audrey, you have a question?
Yeah, hi. So I was wondering, what type of colleagues do you find collaborating or just working well with? Like, what kind of traits do they demonstrate that makes your working more convenient, just like more smooth running?
Yeah, great question. So I think I have a great example of that, because that's sort of the environment I'm in right now. So I have a senior partner who's the chief of division, who is basically my mentor as well. So I think for someone who's going to be your mentor, or or your senior, or the person that's leading in a leadership position, it's going to be someone that keeps you on track in terms of encouraging you, promoting you with colleagues. And especially, I think, when you're talking about gender things, it's something that I think women benefit from as well, because women are looked at with a closer eye in terms of outcomes and certain other measures. And so I think, and for anyone that starts off a career as well, having someone that will introduce you to the group in a positive way, keep you, encourage you, give you opportunities, and be an open channel for you to interact with. So rather than being being the boss, being someone that leads by example, and someone that you see is good with all their colleagues, not just one or two people. So I think that's very important in someone that's going to be your mentor, or your so like their interactions with other people is going to be something to watch out for, than just their interactions with you. So that's one thing. And in terms of other colleagues, I think people that you can rely on, you cover for them when they need you, they cover for you when you need them. Being able to just bounce off ideas, being again, being in a way that promote each other, not all working as a group towards the same goal. Yes, of course, you each will have your special interests and want to progress, but without having to step on each other's toes. Does that answer your question?
Yeah, and I guess just a follow-up question, because anesthesiology has caught my eye. I'm wondering, what are your interactions like with them?
It's, I mean, it's a great specialty, and I don't know that it is right now, but I think at least until about a couple of years ago, that was one of the most sought after specialties. And I think it's a very, very important topic to be, or a very important concept to work well and be in collaboration with the anesthesiologist here at the university, and especially with our cardiothoracic department. We have a very good relationship with them. And especially the sort of cases that we do, it's very important to be on the same page. We try to interact with them prior to a case to make sure that things are going to be as needed. If someone's going to have a difficult intubation, we need to let them know prior to. If someone's going to be an especially difficult case or something's there to manage, rather than just getting into the room and saying, hey, why aren't you doing this or that, having a conversation before. So it's not like they're just at the other side of the screen. I think it's very important to have active involvement from both sides for best patient care. Also, they attend our M&Ms, when we have mortality, morbidity conferences to figure out what went wrong with a patient when something goes wrong. So things like that. We include anesthesia. Anesthesia and us together make plans for enhanced recovery of patients. So there's a lot of interaction going on, and I think that's extremely important.
I think this is gonna be the last one, and it's for Farah.
Yeah, I was just wondering how you cope with, or like what you do when or after surgery, let's say, goes wrong because something unexpected happens or something along those lines. What do you do? Like, what's the process like after a situation like that happens?
So there's a personal process, and then there is, a more formal process. The formal process is that, if something, I think everyone realizes that, there are going to be times when things happen, either because you did make a mistake or because something was just, or it could be that something was just out of your control. But the formal process is that if there is a significant complication, it's something that's always discussed at the morbidity mortality meeting. And so that comes up there. And then also and then if it's something that's identified as something that could have been really avoidable, there's this process called root cause analysis, which, dives down further into how this could have been avoided. Does there need to be a process change and things like that? So that's sort of the formal process of it. And of course, there are other things that, you can put in reports and complaints and stuff like that. But for closure, it's more about, I think the culture is more about trying to find out what went wrong and why, and what we can do better, rather than placing blame. I think that's, and as that sounds very theoretical, but I think if it's like that, then the group and the practice will progress. And if it's the other way, then you're just going to see people coming in, leaving because a mistake happens, and then they're just bombarded for it and they're gone. So I think a positive process, or trying to get a positive out of something that happened. So that's the formal process. In terms of personal process, I think everyone has to find their own way. I think for us here, one good thing's been, having a good group of partners. If something happens, we're almost immediately, calling each other, one, for help in the OR, or if something happens, just discussing about it. Like I said initially, just expressing whatever emotion, not in the OR, of course, getting through that point, and then, just dealing with it for yourself, but then trying to, talk to your colleagues to say, is there something, we could have done, couldn't have done? Is this the right way to go about it? And then just being able to rationalize, I think, is, and sometimes you may not find a reason. It may just be, yes, I could have done better, and I, messed up, and that's just accepting that and moving on sometimes.
Well, thank you so much, Dr. Rao. That was really helpful. I think one of the most informative, virtual shadowing sessions that we've had. So thank you so much for giving us your time, and we really appreciate it.
My pleasure. It was great seeing you all. Thank you.
Thank you.
Mhm.
Thank you.
You.
Bye.
Yeah. Yeah.
Okay, and thank you guys for coming. And there's also going to be another meeting next week, I think Monday. So hope to see you guys then. And then this session and that all the previous sessions and the upcoming sessions will be uploaded to the YouTube. So thank you guys so much.